Dr. Periyasamy to deliver the welcome address. Over to Dr. Periyasamy.
Thank you, sir. Thank you. Good evening to all. Respected academic chairman, Dr. A.L. Minasundram, sir.
Good evening,
President Dr. Suresh Kumar, sir. Treasurer Dr. David, members of ISCA City Branch and delegates. I welcome you all on behalf of ISCA Pudukkottai for the online webinar program Pudukkottai Budan. As you all know, we are continuously conducting this program from March 23rd of March 2022. We selected topics according to the curriculum of postgraduate students, and topics are discussed from 23rd of March 22. All the topics are selected based on that, and now we are conducting today. This program is 31st program, and I welcome you all for this 31st program of this online webinar program. So this program is continuously, we are continuously conducting this program since because of the continuous effort and hard work of Dr. A.L. Minasundram sir and his guidance. It's not only an academic chairman, he is director of this successful program. At this juncture, I would like to thank our academic chairman once again, sir. And I welcome you for this 31st program of this online webinar program. So today we are going to have three important topics. One is anesthetic management of total knee replacement, and another one is anesthetic management of pheochromocytoma, and another one topic is anesthetic management of awake craniotomy. So for the first topic, anesthetic management of total knee replacement, I welcome Dr. Pankaj Ramakrishna Gupta, senior consultant from Nashik. I welcome you, sir. And next topic, anesthetic management of pheochromocytoma. For this topic, I welcome Dr. Neha Kulkarni, a senior resident, Dr. Vasantrao Power Medical College and Hospital, Nashik. I welcome you, madam. And third topic is anesthetic management of awake craniotomy. For this, I welcome Dr. Rahul Dork, resident, Dr. Vasantra Power Medical College, Research Institute, Nashik. I welcome you, sir.
Thank you.
For this 31st program, I would like to thank and invite Dr. C. Sekhar as a chairperson. He's from senior consultant and head Ganga Hospital and Specialty Center, Coimbatore. I welcome you, sir, on behalf of ISCA Pudukkottai. As you all know, our program is accredited by Tamil Nadu Medical Council, and those who are attending this program will be given credit hours. For that, we need certain documents, your ID and your attendance certificates, and 100 to be paid to our account. You have to send these details to the following mail address, isca.pudukkottai@yahoo.com. I will again display in the chat box. You can note it down. So today we are going to talk about it's the most important among the three. Pheochromocytoma is a challenging subject for us because we have to work out for the extreme end of hypertension and hypotension, pre-surgery and after surgery. So pheochromocytoma, a small poem about that. The catecholamine excess leads to catastrophic events before surgery and after surgery. Horse racing heart rate, higher mounted blood pressure, increased sweating and perspiration, intermittent throbbing headache, everlasting hyperglycemia and hypermetabolism. Hit and run, the crisis to prone. Managing them is our main target. making the real life is our motive. With this, I wish you all happy Diwali 2022 on behalf of ISA Pudukkottai. Thank you for the opportunity. Thank you, sir. Over to Dr. ALM, sir, academic chairman.
Thanks, Dr. Periswamy. At the outset, I also welcome every one of the faculty for joining us. It is a real credit that the state Maharashtra has repeatedly taken part, and most of the sessions, the webinars, were having participation by faculty from Maharashtra. So I thank the people who have come as a faculty. And as you all know, we are running it since the March 2022, and we are successfully conducting it. The expectation is more from the anesthesiologists across the country, mainly from the postgraduates. And as a rule, we are making one postgraduate faculty as compulsory one. So this time we are happy to have Dr. Rahul Tour from Dr. Vasantarao Medical College, Nasik. So first time, usually a postgraduate has not talked anything about the anesthetic management. We will be giving only short topics. But the first time, a postgraduate is also talking about a case management, that too, interestingly, awake craniotomy. So in that way, Dr. Rahul scores over the other postgraduates who have talked about small topics like equipment or any short topics like amniotic fluid embolism, like that. But as anesthetic management, this is the first time a resident is talking. So I welcome him. And he is accompanied by Dr. Neha Kulkarni. Dr. Neha Kulkarni is a real anesthesiologist, because real anesthesiologist motto is always be prepared. So she was prepared. We have asked for someone else, but suddenly as we changed the topic, he could not make it up. And suddenly Dr. Neha Kulkarni has come as a joker. Joker means it is not a real joker. In cards, joker is the powerful card. So Dr. Neha Kulkarni is a real powerful card. We wanted to have her as a filling the gap. So she has come here to fill up the gap, but with a smiling face, she has accepted it. Till now, she is maintaining that. So she is a senior resident in Nasik, Vasantarao Medical College, Nasik. So I welcome her personally and my personal thanks to her. And she is coming here to show her prowess in the management of pheochromocytoma, which is a very difficult topic. And many people will be eager to take part and to listen to her lecture. And third lecture for total knee replacement is going to be by Dr. Pankaj Gupta. So Dr. Pankaj Gupta is my long-term friend, more than 20 years, and he will be always soft-spoken and he will be always smiling. Myself and Dr. Pankaj sir has taken part as a chairperson in pediatric anesthesia session in Calcutta. So he is a freelancer, but he has extended his tentacles in all over the area of the anesthesia field. And mainly, more than anesthesia part, he is an active member in ISA PPF. So in the private practitioners forum, he has raised many questionnaires. He is doing many research projects by email and by WhatsApp. So sir is always he is dynamic, and we could not estimate his age, because he will be always younger in academics as well as taking part. So usually we will have a problem when 3 good faculty are there. Then who is going to govern them? So it is Dr. Shekhar. None other than Dr. Shekhar can do that, because he is a head anesthesia department in the prestigious Ganga Hospital, Coimbatore. So people know Ganga Hospital across the country. So Dr. Shekhar is heading the department. And when it is a question of knee replacement, I will be doing 10 knee replacements for 3 months. But Shekhar sir will be doing 10 knee replacements per day. So it will be 10 per day. Ours is only 10 for 3 months. And I don't know how much Dr. Pankaj Gupta will be doing. But see, the most seasoned expert in the field of joint replacement and this regional block and any orthopedic procedure, is Dr. Shekhar. And I know Dr. Shekhar for so many years. Even though he is from a prestigious hospital, he never reveals that. He is a down-to-earth man. He is soft-spoken. Whenever we ask something, he will teach as if he is teaching to a child. Because I am having the maturity of child only as far as academics is concerned. So sir used to take pain, and even our silly doubts he will answer. So we thought total knee replacement, phaeochromocytoma, awake craniotomy, 3 are exam topics. So these are all vital topics. So I extend my personal thanks to Dr. Shekhar sir, who immediately accepted our invite. And now I requested Dr. Shekhar sir to conduct the proceedings one by one. Over to Dr. Shekhar. Thank you, sir. Sir, Shekhar sir, you can unmute yourself and you can start.
Can you hear me now, sir? Volume is coming. Can you hear the volume now, sir?
Sir, this is perfect. You can go ahead.
Okay, sir. Good evening and thanks to Dr. Elam and everybody. You can feel free to talk to me. There's no problem. Anyway, we'll start the session and go for the discussion so that we'll save time for the discussion sake. Over to, I think first is Dr. Neha. Am I right? Or the other person? Dort.
Dr. Rahul.
Rahul can start the session. Over to Rahul.
Good evening, sir. Good evening, all. Myself, am I here audible to all?
Yeah, go ahead.
Yes. Sir, myself, Dr. Rahul Thorve, resident from Department of Anesthesiology, Dr. Vasantra Pawar Medical College and Hospital, Nashik, from Maharashtra. Today, I am presenting the topic of awake craniotomy, the anesthetic management. To start with, introduction. Awake craniotomy mainly used for mapping and resection of lesions in vitally important brain areas where imaging is not sufficiently sensitive, that is motor and speech areas. It requires skills, experience, and commitment on the part of the entire operation room team. So the indications are the procedures like which require the electrocorticographic mapping or precise electrophysiological recordings, like in case of the epilepsy or in the deep brain stimulation in Parkinson disease. Then a resection of lesions located close to or into the functionally essential motor, cognitive, or sensory cortical areas. Then third one is procedures requiring the obliteration or resection of the vascular lesions that are essential for vascularization of functionally important territories. And last is minor intracranial procedures like ventriculostomy. Then the contraindications are the absolute contraindication. The absolute contraindication is patient refusal. Then in the relative contraindications are neurological, psychiatric, airway like things, and tumor characteristics. In neurological things, dysphasia, confusion, cognitive disorders are the relative contraindications. In psychiatric component, claustrophobia, patient is having claustrophobia or mood instability. In airway, uncontrolled coughing, morbid obesity, obstructive sleep apnea, and tumor characteristic like large and highly vascular tumor. Then middle fossa lesions, then uncomfortable, which leads to uncomfortable position or dural pain. Then risk and benefits of the awake craniotomy. in benefits, the benefits are like of surgery, and then functional preservation. So surgeons can map the entire territory of that tumor, and the functional preservation can be done. Then patient is having immediate follow-up post-operatively, that is early recovery, early discharge, then neurological follow-up. And electrophysiological recordings can be done, and patient active participation in the surgery. They are participating in functional testing. Then risk are recurrence of the lesion, obstructive apnea, seizures, nausea, vomiting, bleeding, increase intracranial pressure. Then it's difficult to collaboration between anxiety, pain, discomfort, and willingness to collaborate. Neurological abnormalities like abnormal movements and dysphagia. The objectives of the awake craniectomy is patient's cooperation, then preserved inspection, like difficult intubation sign is patient is of hefty jaw or short neck, or patient is having higher scoring of stop bang, and patient is having obstructive apnea. Second is seizures, patient which type of seizure, frequency, current treatment, then nausea and vomiting, then raised intracranial sign, pressure, like type and size of the lesion, signs of the raised intracranial pressure. In patient is having any kind of bleeding disorders or any medication which are antiplatelet medication. Then patient collaboration for anxiety and neurological problems. Then in anesthetic management, the technique we follow for awake craniotomy is divided into two parts. First one is the scalp block, and second is the sedation. Starting with the scalp block. In scalp block, this is the regional anesthetic technique targeting the nerves that supply the scalp, excluding the facial bone. Scalp has a 5-layer, which mnemonic is in itself. First one is starting with skin, then connective tissue, then aponeurosis, then loose areolar tissue, and last one is the periosteum. The branches of the trigeminal nerve, like ophthalmic, maxillary, and mandibular, supply the anterior part of the scalp, and greater and lesser occipital nerve supply the posterior part of the scalp. Then indication and contraindication for scalp block. Scalp block is indications are awake craniotomy, then supra and infratentorial craniotomies along with general anesthesia. Then VP shunt, that is ventriculoperitoneal shunt placement, and Omeyer reservoir placement, suturing the scalp laceration, then occipital neuralgia like things, and refractory trigeminal neuralgia. In contraindication, patient refusal and allergic to local anesthetic. Relative contraindications are local site infection, any bleeding disorder, or patient is of post-op case of craniectomy. The following nerves are blocked during in scalp block. There are 7 nerves. First is supraorbital, then supratrochlear nerve, the zygomaticotemporal nerve, and auriculotemporal nerve. These 4 nerves are branches of the trigeminal, then greater auricular nerve, and greater occipital nerve, and lesser occipital nerve. The drug used for scalp block is 0.25% of bupivacaine or 0.75% ropivacaine, or 0.25% levobupivacaine with or without 5 micrograms of 1:2 like epinephrine, and volume injected at each site is 1 to 5 ml. The injection sites are important in these things. The injection sites are total 7 injection sites, starting with the supraorbital nerve. For supraorbital nerve, we have to palpate the supraorbital notch, and just medial to supraorbital nerve, there is a supraorbital nerve. We inject the supraorbital notch, then we inject the 1 to 2 ml of local anesthetic. Then medial to the supraorbital, 1 centimeter medial to supraorbital notch, through the same insertion point, medialize the needle, and we block the supratrochlear nerve. Then after that, zygomaticotemporal nerve is blocked at junction of the supraorbital margin and zygomatic arch. At that level, we block in 2 components, because at this level, zygomaticotemporal nerve enters the temporalis fascia. So we have to block superficially and in deep also. So maximum volume of up to 5 ml of local anesthetic volume is injected here. Then Fourth nerve is auriculotemporal nerve. It is present just 1 to 1.5 centimeter anterior to the tragus. Then greater auricular nerve, it locates 1.5 centimeter behind the ear. Then greater occipital nerve is present midway between mustard process and the occipital protuberance. So lesser occipital nerve presents 2 to 2.5 centimeter lateral to supraorbital nerve. Greater occipital nerve. Then complication of scalp block are anaphylaxis to local anesthetic, then toxicity to local anesthetic, hemodynamic changes and arrhythmias due to the accidental injection of the local anesthetic intravascularly. Then vascular injury and hematoma. Hematoma is the most common complication. The facial nerve palsy, intracerebral or subarachnoid injections in cases of post-op case of craniectomy, bradycardia and hypotension due to trigeminal-cardiac reflex and infection. Then in medications, in pre-medication, injection midazolam 1 to 2 milligram can be given for anxiolysis, but in normal neurological function patients. Then anticonvulsants and midazolam should not be given in seizure patient because it hampers the mapping. In the monitoring, there are all the standard ASA monitoring like electrocardiogram, end-tidal ET-CO2, then pulse oximetry and NIBP. Technique used for the awake craniotomy are divided into two groups depending upon the team preference, tumor location, neurological status, body size, age, motivation, and medical comorbidity. The two techniques are asleep, awake technique, and second is awake. In asleep, awake technique, patient is under general anesthesia during craniotomy and closure, and patient is awake during the mapping phase. And in awake phase, a patient is sedated mildly, and the patient is awake throughout the procedure. The drug used most commonly are propofol, fentanyl, remifentanil, and dexmedetomidine. The anesthetic regime for awake craniotomy used are for light moderate sedation, low dose of propofol, that is 20 to 50 microgram per kg per minute or 0.2 to 2 microgram per ml. And remifentanil 0.01 to 0.06 microgram per kg per minute or 0.2 to 1.5 nanogram per ml. Infusions are made like that. And dexmedetomidine for loading dose 1 microgram per kg over 10 minutes, and the maintenance dose is 0.3 to 0.5 microgram per kg per hour. The deep sedation, in deep sedation, maintain spontaneous ventilation, but with the use of an airway device for airway patency, that is LMA. For dural pain, managed with infiltration of local anesthetic along with along the meningeal vessels. So complication of light sedation is first one, the problem like agitation. It can be solved by comforting and empathy to patient, increase sedative medication, reduce the sedation, stop propofol, use dexmedetomidine, give analgesia, and ask surgeon to give more local anesthetic at the surgical site. Second problem would be airway compromise, which causes desaturation and hypercapnia. The solution for this problem is alert the surgeon, call for help, stop all infusions, mask ventilation with jaw thrust and oral or nasal airway, then bilateral nasopharyngeal airways and LMA, and intubate the patient. The complications of the awake craniotomy are first one is the obstructive apnea and hypoventilation. It can be managed by thorough pre-op evaluation, titration of sedation, end-tidal CO2 monitoring, and head positioning. Then asleep technique. And for nausea and vomiting, pre-op evaluation, psychological preparation, we can give injection metoclopramide and injection propofol. The complication like seizure can be managed with pre-op prevention and evaluation and single electrical stimulation. Then a loss of patient cooperation can be managed with short the procedure as much as possible. Then good analgesia, titration of the sedation, and good installation. For hypertension, tachycardia, and trigeminocardiac reflex, it can be managed with optimal analgesia, vasodilators like beta blockers, and topical anesthesia of the dura. Then air embolism is managed with surgical field irrigation, irrigated with normal saline, then head positioning and optimal volumia. And bleeding can be managed with screening for bleeding disorders and avoid other complications. Then post-operative care for awake craniotomy patients should observe in high dependency unit or in intensive care unit. The pain management with small doses of opioids intravenously, oral opioids combined with acetaminophen. Thank you, sir.
Nice, Raghu.
Thank
Good. We'll have a discussion towards the end. I can, Dr. Neha, you can take over.
Good evening, one and all. I would like to thank Dr. Meenakshi Sundaram, sir, for the kind words of introduction. I'm Dr. Neha Kulkarni from Department of Anesthesiology, Dr. Vasantrao Pawar Medical College, Hospital and Research Center. After all the awake craniotomy interesting topic, I hope all are awake. Let me take you through the roller coaster drive with catecholamine rush, and let's manage a challenging topic of pheochromocytoma and see how the anesthetic implications. As this being an academic webinar, I just thought of covering the questions from previous papers for the PG students so that they can understand the pattern, how to, what are expected. So the questions, these are the only prototype questions asked. The questions are like preoperative evaluation and preparation of patient for pheochromocytoma, right? Preoperative evaluation and optimization of a 30 years old male patient with pheochromocytoma. Discuss anesthetic goals and challenges for the robotic assisted excision of pheochromocytoma. Preoperative assessment, preparation and anesthetic management of 16 years old girl posted for lab resection of left-sided adrenal mass. What is pheochromocytoma? What are its clinical features? Discuss the pre-op investigation, preparation and anesthetic management of such a case for surgical removal. Discuss preoperative assessment, preparation and management of 16 years male kept for pheochromocytoma excision. How will you manage post-anesthetic complications? So pheochromocytoma, as we all know, it's a catecholamine secreting tumor of adrenal medulla. 90% is found in adrenal medulla, while 10% is extra-adrenal. Mostly it's sporadic, but 1/3 are associated with gene mutations which are autosomal dominant. It may be associated with certain syndromes like MEN2A, MEN2B, von Hippel-Lindau syndrome, and neurofibromatosis. Here it is important to know that medullary CA of thyroid is also associated with MEN2A. So while investigation, we should think of thyroid function test in case of pheochromocytoma. See in this picture, adrenal gland has been divided into two major portions. One is the adrenal medulla and the outermost is the cortex. Adrenal medulla secretes catecholamines, that is norepinephrine, epinephrine and dopamine. While cortex is further subdivided into 3 layers, the outermost being zona glomerulosa, which secretes mineralocorticoid, the intermediate being zona fasciculata, which secretes glucocorticoids, and the innermost layer of the cortex, zona reticularis, which secretes the androgens. So pheochromocytoma is basically the tumor of medulla secreting catecholamines. It was traditionally believed that pheochromocytoma follows rule of 10, which means it is 10% extra-adrenal, it is 10% malignant, it's 10% bilateral, it's 10% seen in normotensive patients, and it is 10% familial. However, with advancement in diagnostic tools, the diagnosis is being done at appropriate rate, and these numbers are different at present. Pheochromocytoma presents with 5 P's, out of which the first P is pain, that is headache. Second is palpitation. Third is perspiration. Fourth is pressure, that is hypertension. And the 5th P is pallor. Out of this 5 P's, the first 3 form classic triad of symptoms of pheochromocytoma. Pressures, that is hypertension, is present in 90% of patients. However, it may be paroxysmal in 30 to 50%. Some non-specific symptoms like anxiety, lethargy, nausea, weight loss, hyperglycemia, tremors are also present. Symptoms due to end organ damage because of catecholamine release can cause abdominal pain, like due to mesenteric artery ischemia, visual disturbances, pulmonary edema, cardiomyopathy, and myocardial infarction. The tumor, according to the type of hormone it secretes, can present different symptoms. Like pheochromocytoma, which secretes predominantly norepinephrine, may present with systolic and diastolic hypertension with reflex bradycardia. Also, tachycardia can present, but bradycardia is more common with norepinephrine secreting tumors. While pheochromocytomas which secrete epinephrine have profound systolic hypertension, diastolic hypotension, and tachycardia. So depending on the hormone it secretes, also it can have a varied presentation. Okay. Pheochromocytoma, traditionally biochemical diagnosis was dependent on 24 hours collection of urinary catecholamines and vanillyl mandelic acid, blood sampling of plasma catecholamines. However, catecholamines are metabolized into free metanephrines within the tumor cells and are continuously released in the circulation. So metanephrines and non-metanephrines are continuously present in the circulation as against catecholamines, which may be sporadically present in circulation. So it makes sense to measure the metanephrines and non-metanephrines in the plasma and urine. So modern techniques prefer measuring urine or plasma levels of metanephrine and non-metanephrines. Plasma tests are more sensitive, 96 to 100%, than urine tests, which are 70 to 90% sensitive. Both modern and traditional tests have false positive results, and the causes of false positive result may be recent exercise, venous sampling in sitting position, dietary factors, renal impairment, drugs like atenolol, phenoxybenzamine, olanzapine, MAO inhibitors, cocaine, salbutamol, paracetamol, and terbutaline. So one should keep this point in mind while doing the test, that if these patients are on this specific group of drugs, we may get this test to be false positive. Imaging, CT or MRI abdomen are commonly done, out of which MRI is again superior to CT. Scintigraphy is one more imaging technique in which is indicated in metastatic disease or indicated in preoperative staging of extraadrenal paragangliomas. Other tests include positive emission scans, selective venous catheterization, and catecholamine sampling. Surgical approach, laparoscopic surgery is preferred over open in case of adrenal mass less than 6 centimeters and weight of less than 100 grams. Advantages of laparoscopic surgeries are same for any other laparoscopy surgeries, like less post-op pain, early mobilization recovery, reduced incidence of post-op pulmonary and thromboembolic complications, and shorter hospital stay. It also comes with some disadvantages, that increase in catecholamine release can be present due to carboperitoneum, pneumoperitoneum. Persistent tissue traction, diathermy, or ultrasound coagulation can cause sustained hemodynamic instability, which is similar to that with open, but it is for longer duration in case of laparoscopy as against for open, which is of shorter duration. Also, we have to give extreme positions in laparoscopic surgery, which can worsen the hemodynamic instability. So now, preoperative investigation, we have to do all the investigations as a routine protocol, out of which the important ones I'll be mentioning here. CBC and serial hematocrit values are important, because with catecholamine secretion, there will be severe vasoconstriction and there will be volume depletion. So there may be apparently high hematocrit values. So if the patient is properly prepared preoperatively with alpha block, we will get normalization of hematocrit. So we need to see whether the hematocrit values are normalized. That indicates we have optimally optimized the patient well. Second is blood sugar levels. We can expect hyperglycemia in these patients due to multiple causes, which I will be discussing later. With calcium, there is again hypercalcemia if it is associated with parathyroid adenoma, as in case of MEN2A. Thyroid function test, as I previously said, it needs to be done to find out association with medullary carcinoma, as in MEN2A syndrome. ECG is very important as for all the patients. As we can see, the ST-T wave changes secondary to MI, ventricular hypertrophy, arrhythmias, and most of the changes are reversible on treatment. Echo is to estimate myocardial function if cardiomyopathy is suspected. Cardiomyopathy is very common due to catecholamine release. Volume depletion, heart rate and arrhythmia control, assessment and optimization of myocardial function, and reversal of glucose and electrolyte disturbances. Arterial pressure control and volume expansion. Preoperative alpha block is a gold standard for this. And the most commonly used alpha blockers are phenoxybenzamine, prazosin, and doxazosin. Second group of drug is calcium channel blockers. I'll be just covering the drugs quickly. Phenoxybenzamine, it's a non-selective, non-competitive, long-acting alpha blocker. It being a non-selective alpha blocker, it also causes alpha-2 blockade and causes refractory tachycardia, which can be controlled by beta blocker. It being a non-competitive blocker, it reduces catecholamine surge, but may be implicated in post-op refractory hypotension and volume contraction. Patients may need adequate hydration. It being a long-acting alpha blocker, it needs to be stopped 24 to 48 hours before surgery to avoid unnecessary hypotension post-op. The side effects of phenoxybenzamine are nasal stuffiness and refractory hypotension. In fact, these are the endpoints of adequate phenoxybenzamine treatment. The dose of phenoxybenzamine is 10 mg BD. It can be increased every 48 hours to 60 to 250 mg per day. The second drug of alpha blocker is doxazosin. It's a competitive selective alpha-1 blocker as against phenoxybenzamine, which was a non-competitive. So this drug being a competitive alpha blocker, the side effects as encountered with phenoxybenzamine are reduced with doxazosin. So we can expect less tachycardia and less post-operative hypotension with use of doxazosin. Dose is 1 mg, can be titrated up to 8 mg BD. The third drug, prazosin, is a selective alpha blocker, and it's favored because of its shorter half-life and ease of titration to a desired endpoint. The most common side effect is profound first dose hypotension, which can be avoided by giving this drug at night prior to surgery. Coming to the second group of drugs which we are using for preoperative preparation, that is calcium channel blockers. Mechanism of action is it inhibits norepinephrine-induced calcium influx, and it is utilized for hemodynamic control before surgery in addition to alpha blocker. This is very important. It's always used in addition to alpha blocker and not recommended as a monotherapy. The drug commonly used is nicardipine 30 mg BD. So this was about the pressure control and volume expansion. Coming to our second objective, heart rate and arrhythmia control. Tachyarrhythmias result from epinephrine and dopamine secreting tumors and also secondary to alpha block. The non-selective beta blocker should always be started after adequate block to alpha block to avoid worsening hypertension. If beta blockers are started prior to alpha block, we may get uninhibited vasoconstriction and worsening of hypertension. So always should be started after an alpha block. Selective beta blockers are atenolol or metoprolol. The third objective, we have to assess the myocardial function and optimize it wherever required. So as already told, we need to do ECG, echo to rule out cardiac issues. Fourth objective is the reversal of glucose and electrolyte disturbances. Hyperglycemia occurs due to multiple reasons like increased glycogenolysis, impaired insulin release, lipolysis, and increased glucagon release coupled with insulin resistance. So hyperglycemia needs to be treated with standard protocols. Secondly, electrolyte disturbances can be encountered, which may identify catecholamine-induced renal impairment. And thirdly, we can encounter hypercalcemia, which can be corrected preoperatively by isotonic saline or IV bisphosphonates wherever required. So we have tried to optimize the patient. We should need to assess how much is the optimization. So alpha blockade is usually commenced 7 to 14 days before surgery. Some textbooks say it should be started 10 to 14 days prior to surgery. For assessment of adequate optimization, there is a Roizen criteria, which has 4 points. Arterial pressure readings consistently less than 160/90 for 24 hours prior to surgery. Presence of orthostatic hypotension with decrease in systolic arterial pressure of at least 15%, but not less than 80 millimeters of mercury. ECG, which is free of ST or T wave changes for 2 weeks, and no more than 5 premature ventricular contractions per minute. So these are the criteria for adequate optimization prior to taking the patient to OT. So we have done a good job of preoperative assessment and preoperative preparation. Now this is the most important management, where we need to have a good communication with the surgeon and have a meticulous planning for this. So risk factors for hemodynamic intra-op are due to high pre-induction plasma norepinephrine levels, large tumor size, profound postural drop after commencement of alpha blockade, and pre-induction MAP of about 100 millimeters of mercury. Objectives, as like we have seen for preoperative preparation, objectives for intra-op management are to avoid drug-induced catecholamine release. So we should avoid all the drugs which will exaggerate the catecholamine release. Avoid catecholamine release induced by anesthetic or surgical manuals. Catecholamine can be released while due to intubation response, as in case of anesthesia, or due to carboperitoneum, pneumoperitoneum in case of surgical manuals. We need to avoid and take care of that. Minimize hemodynamic response due to tumor handling. When the surgeon is trying to deal with the tumor, there may be catecholamine surge and hemodynamic instability. So we should try and minimize these things. And after the tumor devascularization, we can expect hypotension, which needs to be addressed. Pre-induction, the important goal would be to relieve anxiety of the patient, ideally by giving long-acting benzodiazepines such as lorazepam or diazepam on night prior to surgery, or injection midazolam IV prior to transfer to OT. Monitoring should be attached as per the standard ASA guidelines. I would like to just highlight the most important monitoring which we need to consider, especially in case of pheochromocytoma. Arterial line is mandatory prior to induction. It can be used to monitor beat-to-beat BP recordings. CVP line, it can be inserted after induction of anesthesia so that we can avoid tachycardia and hypertension. If we have a wide wherever required. Third monitoring is pulmonary artery capillary monitoring, which is done by Swan-Ganz catheter or other accurate methods to estimate cardiac filling, pressures, and functions may be needed in patients with catecholamine or hypertension-induced severe cardiomyopathy, pulmonary hypertension, or significant myocardial diseases. Transesophageal echo has an added advantage of real-time monitoring volume status as well as early detection of myocardial wall abnormalities, aiding the diagnosis of intra-op MI. So before I start with my anesthesia, I would like to keep two different trays ready or two different tables ready. One is for hypertensive crisis and the other is for hypotensive crisis. So for hypertensive crisis, I would prefer nitroglycerin, sodium nitroprusside, nicardipine, diltiazem, ismolol, which is a beta blocker for heart rate control. And for this would be loaded in a 50 cc syringes and attached with a PM line and kept ready. For hypotensive crisis, we have two drugs, norepinephrine and vasopressin. If a patient has catecholamine cardiomyopathy, epinephrine and dobutamine should be considered. For patient with RV dysfunction, milrinone, which is a phosphodiesterase inhibitor and a calcium stabilizer, should be considered. So now coming to our objectives of intra-op management. First is avoiding drug-induced catecholamine release. So what are the drugs we need to avoid which cause catecholamine release? So among the induction agent is a ketamine, which causes sympathomimetic action. Opioid like morphine cause histamine release. Inhalational agents like halothane are arrhythmogenic and it sensitizes myocardium to circulating catecholamine. Desflurane causes significant sympathetic stimulation. So inhalational agents like enflurane and isoflurane were traditionally used. However, sevoflurane is considered to be the safest inhalational agent. Coming to the muscle relaxant, scoline causes catecholamine surge from muscle fasciculations. Atracurium, we all know, causes histamine release, and pancuronium is a vagolytic, has a vagolytic effect. So muscle relaxants most commonly preferred are vecuronium and rocuronium. Other drugs like ephedrine, droperidol, and metoclopramide also should be avoided for the same reason. So induction, I would prefer propofol and etomidate. Etomidate has an additional effect of cardiostability. Airway instrumentation should be attempted after obtaining adequate anesthetic depth to avoid tachycardia and hypertension. Attenuation of pressure response can be done by IV fentanyl 1 to 2 mics per kg, IV lignocaine 1.5 mg per kg, ismolol bolus of 0.5 mg per kg, as well as infusions of NTG, SNP, and nicardipine can be started. Inhalational sevoflurane is preferred. Nitrous is benign and can be safely used. Neuromuscular block can be achieved by vecuronium or rocuronium, and opioids like fentanyl, alfentanyl, sufentanil are used. So the second objective of minimizing the hemodynamic response to tumor handling has to be dealt with. Tumor handling can cause profound hypertension, bradycardia, or tachyarrhythmias. So here is where we have our armamentarium of our drugs. So phentolamine which is a reversible non-selective alpha blocker. It causes vasodilatation and reflex tachycardia. Most commonly used drugs are SNP, sodium nitroprusside, and nitroglycerin. They both are nitric oxide donors. NTG is venodilator, while SNP is an arterial vasodilator. They both is more rapid with sodium nitroprusside, and so it is a first-line vasodilator. NTG should be considered in patient with IHD as it causes coronary vasodilatation. However, SNP causes intracoronary steal phenomena and should be avoided in patients with IHD. So dose of SNP infusion is 0.5 to 1.5 mics per kg per minute, which is increased up to 4 mics per kg per minute. Side effect of SNP is cyanide toxicity. However, it is low for infusions which are used less than 12 hours in patients with normal renal and hepatic functions. NTG is adjusted between 10 to 200 mics per minute. We all know tachyphylaxis is common with NTG. However, it is only common if the infusions are used more than 24 hours. Coming to the third drug, nicardipine, which is a calcium channel blocker, arterial vasodilator, and cardiac output is maintained without tachycardia. It can cause persistent hypotension. Esmolol, selective beta blocker with rapid action and short duration. Dose is 500 mics per kg over 1 minute, followed by 4-minute maintenance infusion of 50 mics per kg per minute. Magnesium sulfate its mechanism of action is it inhibits the adrenal catecholamine release. It reduces alpha receptor sensitivity to catecholamine, dilates arteriolar vessels, reduces left ventricular afterload while maintaining a preload. It also has an antiarrhythmic effect. The dose is 40 to 60 mg per kg before intubation, and it is followed by 1 to 2 gram per hour. Dexmedetomidine, it is a centrally acting alpha agonist. In addition to sedation and analgesia, its central sympatholytic action results in reduction in plasma norepinephrine levels. So we have dealt with the intra-op thing, the tumor has been removed. So we can expect hypotension after tumor devascularization. The hypotension can result from our anesthetic drugs, which we have already used. It can be also due to the treatment of hypertensive episodes outlasting a transient catecholamine surge. After devascularization of tumor, causes of hypotension are residual alpha block or abrupt catecholamine deficiency after tumor resection in combination with catecholamine receptor downregulation. So the treatment is stop hypotensive agents, adequate fluid therapy, norepinephrine, and vasopressin. Vasopressin is considered only if hypotension is refractory and it acts on V1 and V2 receptors. The dose is 0.4 to 20 units followed by 1 to 3 milliunits per kg per minute. So we have dealt on very well up till now. Pain needs to be taken care of as pain can cause hypertension, tachycardia in post-op period. So multimodal approach with IV analgesics, IV paracetamol, IV tramadol, and IV opioids. If the surgery was open, we can go with mid to low thoracic epidural. And if the surgery was a laparoscopic approach, bilateral tap can be considered. So the patient is dealt with the surgery. Now post-op care. The most common complications which we can see in post-op are post-op hypertension. Causes are post-op pain, coexisting essential hypertension. The patient along with pheochromocytoma may have essential hypertension, or there may be full bladder, fluid overload, inadvertent ligation of renal artery which causes hyperrenism, incomplete tumor resection or metastatic disease. And even without recurrence, hypertension is present in 26% patients for 5 years and 55% patients for 10 years. So these patients need a follow-up for at least 5 to 10 years later after the surgery. Post-op hypotension causes are surgical bleeding, inadequate fluid resuscitation, and residual anesthetic induced vasodilatation. So the treatment is again fluid therapy, and norepinephrine or vasopressin can be started if required. Indications for lifelong steroid is bilateral adrenectomy, and the regimen is initiated before operation. The dose is 100 mg of hydrocort is administered every 8 hourly. In first 72 hours post-op, hydrocort dosage is weaned to 25 mg BD before being converted to oral prednisolone. But this is indicated only in bilateral adrenalectomy and not in unilateral. The third complication after post-op hypertension is hypoglycemia. There may be rebound hyperinsulinism, and this may cause hypoglycemia. It can be treated with regular blood glucose monitoring and titration of dextrose infusions. So now this is about the pheochromocytoma, where we know the patient is having pheochromocytoma and is getting treated for the pheochromocytoma. Now, if we get a patient who has an incidental finding of pheochromocytoma and coming for non-pheochromocytoma surgery, so we should, the symptoms which they present are hypertension, arrhythmias, cardiac failure associated with hypotension, and pulmonary edema. So intra-op management, if it's an elective surgery, we should take the time and optimize these patients. But however, if this is an emergency surgery, we need to waive the risk-benefit ratio and go ahead with this surgery after informed consent and after explaining the patient and relatives about the due risk. Intra-op management, factors triggering release of catecholamine should be eliminated. Invasive arterial line is mandatory, and hypertension controlled by use of alpha blocker like phentolamine or nitrates. Severe tachycardia to be avoided or treated with beta blockers like esmolol. Surgery to be terminated as soon as possible. Catecholamine surges may persist post-operatively, and it may cause myocardial or cerebral infarction, acute kidney injury, or mesenteric ischemia. These patients need to go to ICU or high-density unit post-operatively for all these reasons, even if the surgery is minor for which they have been posted. So just few lines about pheochromocytoma in pregnancy. Presentation can be confused with gestational hypertension or eclampsia. Lab diagnosis is same, like assessment of fractionated metanephrines and normetanephrines in blood and urine. Pheochromocytoma excluded if plasma-free metanephrine is negative. Preoperative alpha blocker is considered safe, with caveat that the blood pressure should be maintained to perfuse the uteroplacental circulation. The optimal time for resection of pheochromocytoma is second trimester before 24 weeks. Patients with pheochromocytoma, resection is recommended simultaneously with C-section or after delivery. So these are my references. And I would just take this opportunity to thank Dr. Meenakshi Sundaram sir, Dr. Pankaj Gupta sir, ISA Pudukkottai City Branch, my seniors, Dr. Sunita Sanklecha and Zadav sir, my colleagues, and all the members present today here. Thank you so much for giving me this opportunity. Thank you.
Thank you, Neha. This is actually, anesthesia told, no, it's a physiological play on it's a pharmacological play on a physiological ground. Actually, the pheochromocytoma will be the ideal situation for this, where you play with pharmacological drugs on a physiological ground. Good. Congratulations.
Sir, does the robo, anything you suppose we're going to use a micro robot?
Pankaj sir has come?
Yes, sir, I'm here. Neha, can you stop sharing your screen?
Yes, sir.
Please stop sharing your screen so I can then get online. No, you're still sharing the screen.
Yes, sir, I'm just doing it.
Yeah.
Yes, sir. Sir, no, sir. I don't think this is the biggest community here. Yes, sir. The ilioischial line is actually tracked. So the posterior column should be very good.
Actually, there is some problem. I feel my lights have gone in my place. The internet has become a little slow.
We'll wait, sir. No problem.
Yeah.
Sir, you can switch off your video and you can talk, sir. Dr. Pankaj, sir.
Yes, sir.
You can switch off your video and you can talk so that your internet connection will be stable. Now it is not getting shared, your screen.
Okay, it's not sharing. Okay. Okay, that's a better idea.
Yeah, I think it will come.
What happened? Okay, there was a huge thunderstorm in Nasik, and all the lights have gone. So everything is running. Okay, now everything is running on
UPS.
UPS.
Then, sir, then you just give it as a lecture instead of sharing your PowerPoint.
Yeah, I feel I've just got the PPT now, sir. Can you see my PPT, sir?
No.
Not it.
Okay. So I can start sharing. Yes, share screen. Anesthesia for total knee. Yeah, now can it be seen, sir?
It
It is getting
starts.
shared, sir, but it is not come.
Yeah, now it's come.
It's come, no?
Yes, sir.
Okay.
Yes.
I don't know. In Maharashtra this time there is so much of unseasonal rain. One of the most unexpected thing which is going on in Maharashtra. There was a huge thunderstorm, and all the lights in my area have gone. So I'm on basically UPS. Everything is very slow. Bad. In fact, I have a full-fledged inverter. I feel now, is it seen, sir? The screen is seen?
The screen is seen.
Okay, so now I will now my presentation to start. Yeah. Am I audible also, sir? No problem, no?
Yeah, audible.
Okay, great. First of all, I would like to thank the Tamil Nadu branch for giving me an opportunity to share my experiences on something which I've been doing for the last 20 years. Of course, as Dr. Meenakshi sir said that Dr. Shekhar does 10 maybe in a day. I may be doing 10 to 15 in a month, but I've been doing for the last 15 to 20 years. And I've seen the graduation. Of course, unfortunately, I work in not in an institute. I work in a private hospital with an orthopedic surgeon, and because of that, I'm not accessible to sonography. So all the new things which have come up, like the adductor canal block and all that, I have not really had access to it. So we still, my talk will be based more on little of what I do more in private practice. And of course, I will theoretically, because I feel most of the audience are students, they would know what is important from their exam point of view. And I bring you greetings from the ISA Square in Nasik. This is a beautiful monument built about 8 years back maybe. If any of you ever come to Nasik, please do visit this place because it is a beautiful monument, and I feel it's only one of its kind in the country, or maybe even in the world, because no one ever has thought of having a square named after ISA. So coming to my talk proper, the challenges that we face for total knee replacement are basically the patients are all elderly with decreased organ functioning and reduced reserves. They have a lot of comorbid diseases. Managing the pain is a very important thing in TKR surgeries. Most patients may be obese, and the challenges of obesity may have to be considered. And of course, many of these patients are on polypharma, so the consequences of that have to be taken care of. The cardiopulmonary reserve is very difficult to assess because basically they cannot do a stress test or they cannot be on the treadmill. So that's why a resting ECG becomes very important. And if it's showing us some silent ischemia or a previous MI, we have to be definitely be careful. And of course, the dynamic functions or pharmacological stress test becomes very difficult, as I mentioned, to look into. The bedside testing like simple auscultation, ECG, X-ray chest, we can definitely come to know whether the patient is having any decompensation. Echocardiography, I feel, is one of the very important gold standard, which I feel almost all TKR patients should be subjected to, especially if it's a bilateral TKR. Electrolyte, CBC, which are all important from the pre-op and even post-op management point of view. The screen is not moving now. The lights are really giving me a bad time. Oh, no. Am I screen sharing gone?
Yes, screen is gone.
Oh, my PPT itself closed down.
Sir, if the
Yes, sir.
screen is seen to you, you can give it as a lecture, sir.
Yes, sir. No, but it will
If
be better
you-
to have a proper PPT, sir. It makes it
Yeah,
more
that is fine,
better. Because
but when it is difficult, when the nature is not cooperating with you, we have to adapt to the nature.
yeah, I know. I agree, sir. But always good to have an impactful lecture.
Because there is a slackness.
Yeah. I'm audible
That's the
otherwise,
reason why
right?
we log in at 5:46. Yeah,
I'm
yeah,
otherwise,
it's clearly audible.
yeah. Right. So most of these patients who come up for surgery are usually senior citizens, and I said they have to have a very proper evaluation, and the bedside tests are the best way to know the cardiac status of the patient. And okay, I've got the screen back now. Okay. Can my screen be seen, sir, now?
Slides are not visible, sir. You are visible.
Okay, I am visible.
Slides are not seen.
Okay. Okay, so I'll just continue with the talk, sir, then. Huh? Of course, the other thing.
That is better.
Yeah. Right, sir. So, as I said, the bedside ways are the best way to evaluate the patient. And of course, there are revised cardiac risk predictors, like the patient having a history of ischemic heart disease, congenital heart failure, or a cerebrovascular accident, or a patient of diabetes mellitus, or the patient has some chronic kidney diseases, and the type of surgery. By this, we can have cardiac risk predictors. And I believe that it's always good to involve in private practice. We always involve the cardiologist, so that we have the risk of the perioperative risk of MI is known to us. We also have to examine the musculoskeletal system of the patient, whether there are any other joints involved, because positioning can sometimes be difficult. Rheumatoid arthritis is a big thing that these patients may be operated upon for the TKR. And of course, whether there's any TMJ joint involvement in case patient is requiring intubation, restricted mouth opening is a very well-known thing with them. Other important thing is in the pre-op, we have to consider is about the drugs, whether the patient is on anticoagulants like warfarin, aspirin, or clopidogrel, or the patient may be on antihypertensives like beta blockers or on anti-diabetic drugs. So depending on the individual medical condition that the patient is forced to, we have to manage the patient accordingly. The ASRA guidelines, this have now made it very clear that the patient is on aspirin, say 75 milligram per day, there is no problem, and it can very well be continued in the perioperative period also. But other drugs like ticlopidin has to be stopped for about 2 weeks. Clopidogrel may have to be stopped for about 5 to 7 days. Aboximab may have to be stopped 24 to 48 hours. And itofibate or tirofiban may have to be stopped 4 to 8 hours before the surgery. The investigations, as I did mention, the renal function test, the coagulation profile, and X-ray chest is very important. The choice of anesthesia depends basically on the surgical factors, the patient factors, and the estimates of the risk associated with the anesthesia techniques. The anesthesia techniques that have been used for TKR are in private. I feel one of the most common things which I have been following is the combined spinal epidural approach. Sole epidural or sole spinal with some additives, a GA with femoral and sciatic nerve block can be given if required. A femoral and sciatic femoral block alone can be done. A lumbar plexus block can be done, or the patient can be straight away put under GA. There are some contraindications for neuraxial blockade, of which the absolute contraindication will obviously be the patient refusal. If the patient is on coagulopathy, we obviously would not like to give any central neural blockade. Any local infection in the spinal area, or the patient may have a raised ICT, patient may be not allergic to drugs, or of course, if the patient has severe aortic or mitral stenosis, then obviously regional techniques are contraindicated and you will straight away think of general anesthesia. Some of the relative indications are if the patient is uncooperative, pre-existing neurological deficits, demyelinating diseases, and if the patient has severe spinal deformity, we will definitely think of giving the patient general anesthesia straight away. Some of the adjuvants which are being used these days for spinal or even for spinal with epidural are the opioids like fentanyl. Clonidine was very popular till recently. I feel now dexmedetomidine has become very popular among most of us. And of course, when the patient is given a central neuraxial blockade, a light sedation or a propofol infusion definitely helps us. Dexmedetomidine, I feel I would just like to mention a little bit about it. It's a very highly selective alpha-2 agonist, and it is 8 times more selective for the alpha-2 receptors than clonidine. And my observation is that the bradycardia that was noticed more often with clonidine is less seen with dexmedetomidine. And the sedation also of dexmedetomidine, it is as good as a near normal sleep. So even dexmedetomidine has become one of my favorites in putting the patient to sleep or giving it some mild sedation. Some of the monitoring of the patient required, obviously the routine monitoring, the NIBP, ECG, pulse oximeter, capnograph, the urine output has to be monitored intraoperatively. The drugs that are required perioperative, I feel the previous night we usually give the patient some antacid. Within an hour of the surgery, the antibiotic is given. Antacid prophylaxis introp also definitely helps because most of these patients are elderly. And of course, if tranexamic acid is a hot favorite among even the orthopedic surgeons, usually we give up to 3 to 4 grams can be given in a day. The protocol that we follow is we give 1 gram 2 hours before the surgery, 1 gram just before the tourniquet is released, and about 1 gram in the postoperative period. Something about the tourniquet. Tourniquet is a very important thing for because most surgeons I have seen have prefer using a tourniquet. And it's properly exsanguinated tourniquet. We have to remember that tourniquet pain can always occur, say about an hour after the tourniquet being applied. Tourniquet time has to be strictly monitored. Usually in the lower limb, we allow around 90 minutes. And at tourniquet release, we have to be very careful as anesthetists. Usually, the surgeons prefer a very cold atmosphere in the operation theater. So having a patient warmer is very absolute, because the temperature is usually kept between 16 to 18 degrees. So keeping the patient warm, most of the senior citizens that I've seen, they are more scared about the temperature of the OT rather than the surgery or anything else. I've had some patients, some doctors, relative father, who told me, I'm not bothered about the surgery, I'm bothered about the cold that you orthopedic people keep in the OT. So always having a warmer is very important. One important thing about tourniquet, which I would just like to mention, is usually when we preload these patients, the preloading has to be a little less in these TKR patients because one, they are elderly, and when they are exsanguinating, almost 800 ml of blood is released from each limb into the circulation. So if the patient is compromised, there is a very high chance of the patient going into CCF. So that's one thing we have to be very careful about when using a tourniquet. Something about bone cement implantation syndrome. That is any hypoxia, hypotension occurring with or without loss of consciousness. This occurs mainly while cementing, while inserting the prosthesis, while reducing the joint, or at the release of tourniquet, as I mentioned. So you have to be very careful of this BCIS, because the patient can go so bad on table and the patient can even land up into a cardiac arrest. So be very careful about bone cement implantation syndrome. Most surgeons always like to do a local infiltration after the implant has been placed and the cementing has been done. And usually they use like a combination of drugs. I feel ropivacaine has become the recent favorite of most surgeons, or even levobupivacaine. They usually add a local steroid if the patient is not a diabetic, and ketorolac or clonidine is what most of the orthopedic surgeons prefer as as a postoperative infiltration. Postoperative analgesia, as I said, is one of the most important things to be managed in TKR. Right from fentanyl patches to buprenorphine patches to transdermal PCA to transdermal fentanyl PCA are important. But I feel nerve blocks are, I feel, the golden standard for almost all TKRs. As I mentioned that because I don't have access to USG, I am using more of a combined spinal epidural technique. I usually, along with bupivacaine, I give some dexmedetomidine, and the epidural helps me in case the surgery is prolonged or even for postoperative analgesia. Of course, my favorite drug is ropin in the 0.1%. Adductor canal block is one of the most important. Actually, I had some good photographs of adductor canal block. This is, I feel, the most important block which is being used for all TKRs, especially the ERAS protocols where they want the patient to stand up on the evening of the surgery. They are saying that adductor canal block is, because it is purely a sensory block, it is one of the best ways of giving postoperative analgesia, and the patient can literally get up from the bed in about 6 to 12 hours postoperatively. There are continuous adductor canal infusions, which are a catheter can be inserted in the adductor canal, and there are continuous infusions which can be put. Some of the other blocks that can be used are the IPAC block, or or even the genicular blocks. There are various blocks, as I mentioned in my previous slides. Post-operative care is very important. We have to support the oxygenation for at least 24 to 46 hours, control the pain, preemptive analgesia, which I forgot to mention because I lost continuity of my slides. This we always do. We do give a dose of celecoxib or something in the preoperative period. Maybe even 1 gram of paracetamol before the incision definitely helps. Cryoanalgesia is one thing which I have found very good in the postoperative period. The moment the patient is shifted out into the postoperative room, a cryo cuff, which is an ice-filled cuff that can be applied to the knee, and it is provides a cooling effect to the knee and also applies pressure to the arthroplastic site. Because of this cooling, the local anesthesia absorption is delayed, the analgesia is better, and there is better physical support to the joint. Some of the complications that can occur in the postoperative period are bleeding, and one important thing is DVT. Clinical DVT is found to occur in 10% of patients where there is no prophylaxis given, and fatal pulmonary embolism has been found to in around 0.4% of patients. So always use whatever strategies you can to prevent DVT, such as avoid dehydration, early mobilization. Regional anesthesia is a good way of preventing DVT. Intermittent leg compression devices are available today in the market, and I'm sure in institutes like Ganga they must be using it very often for almost every patient. There are graduated compression stockings which are available. For prophylaxis, the drugs that are used are low dose heparin, low molecular weight heparin, which may be started maybe even in the pre-op period for some selective patients. Warfarin, I mean, I would not like to use that, but it is mentioned that it can be used as prophylaxis. And always remember that there should be a 12-hour interval between the low molecular weight heparin and the neuraxial block when you are inserting and when you are removing the epidural catheter also. Simultaneous bilateral TKR, I feel there are a lot of advantages because in a single anesthesia exposure, both knees are operated upon. The post-op analgesia definitely helps. There is reduced rehabilitation and early return to the regular work function. But a recent court case which went against the surgeon, I feel now there are a few surgeons are reluctant these days to do bilateral TKR, but I feel the advantages are quite a bit. So we do a lot of bilateral TKRs even now. Of course, with the consent, we mentioned to the patient that we will do the first knee. If everything is fine, then we will go ahead with the second knee. If you find there is a problem, we will not do the bilateral thing. We will just do one knee at one time. Some of the disadvantages of doing a bilateral TKR, of course, the perioperative complications can be high. Blood transfusion requirement may be more. Patient invariably we keep in the ICU. And of course, I feel that anesthesia for TKR is quite a challenging thing for anesthetists, especially in freelance practice when you're doing it all alone. A careful PSC is very, very important. Pre-op optimization of patient is very vital. Always have safe intraoperative anesthesia techniques, because safety in anesthesia is foremost for all of us. A very good post-op pain relief plan has to be managed along with the surgeon. Very good post-op follow-up is very important. And of course, these days physiotherapy started very early, as soon as 6 hours post-operative. A good rehabilitation helps in a very long way. I thank you all for a pleasant listening. Questions are welcome, and I'm extremely sorry because of the weather. This one I could not share my slides. I had made some good slides, but unfortunately I could not share them. So I thank you all, and I'm sure we'll continue with the discussion. Thank you, sir.
Thank you, sir. Thank you. I will do a minimal information before they ask the questions. So I usually think of pre-op, intra-op, and post-op as a perioperative problems of TKR. So first the thing is be careful about these patients, because they always have degenerative scoliosis, because you can't take it lightly that you can give spinal to anybody. Even with the experience of 25 years, still I sometimes struggle to give a spinal in these patients, because they have a degenerative scoliosis. The rotation of the vertebral body and the osteophytes makes it really, really life miserable. So better to warn these people about these things. And few things about this is bilateral. Intraoperatively, there is a double tourniquet release. So the amount of metabolic products released into the system is so high. So the immediate perioperative complications is really, really tough to manage these people. Never think that TKRs are safe with cement implantation syndrome, because even under tourniquet, the embolism can take place and there can be a sudden bradycardia and near arrest situations. So always watch for when they put the cement, not before the tourniquet release, when they put the cement. Remember that putting the cement under tourniquet is safe, is not the real true things you should take care of about that. The bilateral TKRs is advantages on the table, but the problem with the TKRs is they don't bleed on the table. They bleed only at the post-operative period. So each knee, if it collects about 600 to 700 ml in the next 1 hour time, the acute loss is phenomenal in both the knees. Because if you take about 600 ml in each knee, it becomes nearly 1 to 1.5 liters, which these elderly people will not tolerate. And you cannot rush crystallize to these patients and bringing the blood at that cold temperature and then giving it immediately. And so many practical problems will be there. So bilateral tourniquets are safe on the table, but really, really problematic in the post-operative. Look for it. Be mentally prepared for all these things. That's what I used to say. And then the thing is like aspirin regarding this, they always have a capillary ooze. The knee becomes edematous on the first post-operative day. And especially in our people, I think aspirin better to stop. I will tell that in our experience, we always see that all these geriatric patients, you continue aspirin and then make them starve with their relative anxiety and stress on the pre-op period. The post-op GI bleed begins. And it's really cumbersome, and then from the second day onwards, they find it as abdominal distension. Then they have a melena, and then GI bleed begins. So, in my personal preferences, I also like to stop this aspirin also in these patients when it is given. It would always better, I think, in terms of giving Cluxane for these cardiac patients who are on aspirin or a stent who are on dual platelets before, for the stent's sake. Regarding this analgesia techniques for the TKR is always debatable and things like that. Even though the gold standard is epidurals, epidurals also can fail because of the dissipation of the drug in the epidural space is very unpredictable in these patients, the elderly patients. They can have osteophytes blocking the movement of the drug. They can have a scoliotic tendency where the drug doesn't spread. And your catheter placement cannot be exactly in the midline, can be anywhere in the dural space between the intervertebral foraminal areas, can get kinked, because all this is possible. So be mentally prepared for all these things. If you anticipate these troubles, then you will be mentally prepared and you will be looking for it. That's what I wanted it. And regarding the blocks, subsartorial adductor canal block, first my suggestion will be like your block can fail. However, you are great, your block can fail. First, be mentally prepared. So give the block with the thinking that it can happen at all. And a lot of mechanisms are doubtful about this adductor canal block is mainly because of this. The group of nerves which are below the sartorius, if you remember the femoral canal anatomy, the femoral nerve divides into multiple branches below the sartorius when it crosses the femoral canal, the femoral triangle. In the adductor canal, when you give the drug subsartoriously, it spreads. You would have read about something, vasoadductor membrane block and all. These are all in the same area where the plexus forms between these nerves, which supplies the quadriceps muscles. So the spasm pain is the primary indication of these things, because the sensory nerves afferents from the knee joint are taken along with these nerves only, motor nerves and the sensory nerves together as a mixed nerve. So if you see, the knee joint is supplied by, I think if you remember the anatomy, Hilton's law. Am I audible? Some noises coming like ALM's.
Meenakshi sir is
Noise is coming. Well, am I audible at least?
Sir, audible. Extra noise is coming.
Okay. So the pain spasm pain is the most important to break it up. So when you block these things, usually it gives us the pain relief, adductor canal, it blocks it. Hilton's law says that the muscles which crosses the joint, the nerve gives a tick to the joint. So if you see all around the knee, there are so many nerves which is going to supply the knee, but we don't give block to all these things. For a simple reason is, if you take the capsule and the penetration, the capsule is disturbed only anteriorly. Very rarely they do posterior capsular dissection or injury to the posterior capsule. Very rarely. In a TKR, primarily it's only the anterior capsule which is stacked up. So if you give a block in the adductor canal, it's more likely to be given a 90 to 95% of the pain relief. If at all, if you have a posterior loose body removal and then the posterior tibial fragment injures the posterior capsule, then we can go posterior in the popliteal fossa and supplement a little less concentrated drug along the posterior capsule close to the popliteal or posterior tibial artery level. That area, if you give a drug, it will spread along the capsule and the pain will disappear better. And one more thing is, even in the adductor canal, you can have a quadriceps weakness. So better not to make the patient stand thinking that it's only a sensory block. So still they can buckle. So be careful about that. CPM, yes, we do the CPM immediately after the surgery within 2 to 3 hours. We put a CPM on because patient is lying down and the machine is going to bend the knee and extend the knee. That's okay, but standing, we always allow them only on the next day morning. But on the safety side, it's more profile. Okay, anyhow, I open for the session. If you have any doubts, I'll try to talk about it.
So what is your gold standard in Ganga Hospital? Adductor canal or epidural?
Adductor canal. So we stopped even putting epidural nowadays because of our surgeons finished by about 45 minutes to 1 hour, 15 minutes, maximum 1.5 hours. So we give only spinal nowadays. Though we stopped giving epidural also nowadays. Unless we think that there is varus valgus deformity is very high, which may extend time, then we put epidural. Otherwise, we only give spinals. And then the patient will receive adductor canal block in the post-operative ward as the time is lapsing around 2 hours, something like that, so that it will take over that. I give it in the post-op as the patient starts moving, mainly because of 2 reasons. Now, we know that the endpoint of the block will be known immediately. Patient started feeling sensory and then motor, and then suddenly they lose it or the pain is disappearing. The patient is also very happy. So I don't give it immediately in the theater once the surgeon finishes his case. Shift him to the post-operative ward, wait for them to recover a little bit, and then give the adductor canal block. Rarely I supplemented the popliteal fossa. When there is too much of osteophytes, they break in the posterior tibial condyle, something like that, or a collateral ligament doesn't move, something injurious happened. Somewhere with the posterior capsule has to be involved. Initial days, surgeons were giving this Ranawat's block in the capsule, which now we modify as a pericapsular block or the genial plexus block on both sides of the knee joint outside the capsule. Principle remains the same. All the nerves enter through capsule only to the synovium of the knee joint. So if you block around the capsule, then the synovium is the most sensitive portion and the periosteum of the bones. And they cut the periosteum of the bones and remove that off. So the relative periosteum inflammation response is very less. So the pain is mainly because of the partial synovial membrane covering that areas and the capsule. So parapatellar incisions, when the capsule is torn apart and then resutured, that's the most important pain producing factor, which is dealt with adductor canal block. As usual, a little bit of narcotics to make them sleep off better.
So open to the adductor canal block only once, sir. You don't have to repeat it again.
Usually they settle off with 1 block. Sometimes they repeat after about 10 hours. It varies with the patient's sensitiveness. That's all.
Sir, there are 3 questions in the chat box.
Yes, I'll complete once in there. I have also had adductor canal block insufficient and then forced to give femoral nerve block. So accept that. That is because of this adductor canal block is not a complete one to give that. So if the adductor canal block is incomplete or inadequate, patient says still I have pain, give a femoral nerve block. Only thing to make them not to stand on the immediate next day or look for a buckling or anything like that. Be supportive and then watch them up. That's the only thing.
My take on that. Yes, sir, just a minute. My take on this adductor canal block is, sir, that there are almost 10 nerves which cross the knee joint. So we are blocking 1. So invariably the patient is going to have some amount of pain because of something. That's why not give a central block. This is my thought process about it.
Yeah, the epidural has its own, what do you call it, as side effects like catheterization requirement. And then the opposite muscles are also becoming weak. Then the DVT chances becomes very high because you are paralyzing that whole thing.
Yeah.
Even though you talk about that sensory epidurals or walking epidurals and all, theoretically, we don't have a line of demarcation between these two. When you give a little more drug, your motor paralysis set in. When you give less, patient may have pain. So especially when the roots are not fully covered by the drug spread, then you don't know how much dose you are increasing. When the patient says pain, you give an incremental dosage, which will turn effectively into a motor blockade. So that's a problem with the epidurals. That's all. Though it's a gold standard.
Sir, check the questions in the chat box, sir. Sir, in chat box, there are a few questions.
You're telling me, sir?
Sir.
No, it's to me or...
Yes, sir, it is a common question because, see, the question is, can the peripheral nerve block can replace like femoral and sciatic nerve block? can it replace central neuraxis block? Either you or Dr. Pankaj.
I don't think so, because the analgesia that you and the relaxation that you get with a proper spinal epidural, femoral sciatic can be used as a compromise situation where the patient has some problems and you would not like to give the patient epidural. But I don't think it can replace. I personally feel that.
Sir, the chairperson and you are practicing a different technique, right? Now, my
Yes.
question is, if you are doing adductor canal nerve block
I'll
and
answer.
sciatic, will it take care of a tunicate pain?
I'll answer this adductor canal and then femoral sciatic nerve first. Your question. So femoral and sciatic nerve cannot replace the spinal for 2-3 reasons. One is though the femoral and sciatic are the prime nerves which supplies the lower limb, but you forgot about the obturator nerve, posterior cutaneous nerve of thigh, which comes separately. So there are few nerves which cannot be blocked by these 2 nerve blocks. That's very important. Remember, analgesic block is something different and the surgical block is something different. In an upper limb, the scenario is totally different. Lower limb scenario is totally different because in upper limb, the nerves are accompanied by the vessels completely as a close together. So when you give one block, it takes care of the entire thing. And one other thing is there is a sympathetic system which takes light touch and light pain along with the arteries. So the sympathetic nerve supply is along with the arteries, where you block the artery along with the nerves in the upper limb blocks, especially in the supraclavicular brachial plexus block. Whereas in lower limb, the femoral artery is never given a drug or close by. So the sympathetic system is intact in the lower limb when you give only femoral nerve block and a sciatic nerve block. So sympathetic light touch and light pain persist. Obturator nerve is not completely blocked by your femoral nerve block, or even if you supplement in the obturator nerve in the adductor magnus area, you are only giving a partial. The posterior division, we don't know how much it is covering. Again, you are in a deficit level. Third is the posterior cutaneous nerve of thigh, which travels along the sciatic nerve a little away from it. It is never blocked by your sciatic nerve because you are giving the sciatic nerve within the endoneural sheath, which never allow the drug to spread to the peripheral areas of the sciatic nerve. I don't know whether I'm conveying the message. For example, if you give it in the brachial plexus, you have a cords, but the drug spreads far away from the cords, 2 to 3 centimeters or 5 centimeters away from that along the subclavian artery, and even this spreads to the subcutaneous planes, facial planes, everywhere it goes to the infraclavicular area and all. Whereas when you give a sciatic nerve block, it spreads within that sheath. Very important. Within that sheath only it travels up and down. It never goes outside the sheath. So the posterior cutaneous nerve of thigh, which is a component along with the sciatic nerve, comes down, is never blocked. So that's one another reason when you give a tunicate just above the mid thigh, for any other reasons, you give a sciatic nerve block and a femoral nerve block, surgeons will be happy, but the patient will not be happy because the tunicate pain is still persists. Yes. Obturator and that posterior cutaneous nerve of thigh is not blocked at all. So patient will start complaining of pain. So spinal, that's why spinal still remains the gold standard. You are 100% foolproof and all. And there's one other thing that is always against with me is when there is high risk patient, these people think that they can manage it with the nerve blocks. Absolutely not correct, because that is the place where I want an 100% foolproof technique. I want a spinal which I know that it is 100% foolproof. You give a block, then the patient says pain intraoperatively, halfway through, then you start with narcotics, propofol, then mask holding, and then inhalation agent. Then it becomes a little chaos. You can manage this issue. That's a different thing. You can always manage a case, but how you're planning and doing it is something different. So in these patients, I would like to have an epidural and a low spinal drug, and then supplement along with the epidural, go ahead with it. So high risk patients only I want a spinal, which looks little like funny, but this is my explanation why I want that way.
So what I prefer is, fortunately I've just got lights back in my house. What I prefer is a low, in high risk cases, give a low spinal and keep the epidural as a backup arrangement.
That's a supplement in the epidural as you go up.
Is required.
Sir, what is the ideal post-operative analgesics you use in TKR or technique?
Okay, the standards, paracetamol 1 gram IV 8th hourly, and then adductor canal block. We always supplement narcotics to these people at bedtime. Ketorolac, SOS. So usually they receive 1 ketorolac on the table. The most of the time, this is more than adequate, because if you take TKR, if you what you call it as the pain producing factors in a surgical plane, you do a laparotomy, you dissect so many layers, you injure so many muscles. The thing is, in TKR, and both bones or periosteum is being replaced by the bone cement and the prosthesis. So the tissue damage, what you have done is exclusively parapatellar tendon. Major incision is done on that. After that, it's only subcutaneous tissue and skin. So when the subcutaneous tissue and skin are taken care of by the adductor, is relatively much clear. So the pain relief by this adductor canal and little narcotic, so that something is being given to them, and paracetamol as a chemical arachidonic acid pathway blocker should be reasonably good. That's why that is our standard practice. We have about 95% satisfactory patients. Of course, we also have these patients who say that their pain relief is inadequate and all.
Sir, another question is in the chat box: is there any local action for clonidine?
To be honest, I don't use clonidine.
But it is a favorite among the surgeons, but I've seen a lot of surgeons using clonidine.
Well, intrathecally, I don't add any additives. When I am there, I don't add any additives.
No, he's asking. No, the question is there any local action? Okay.
There are, what do you call it as, the multiple receptors in the nerve endings. It's not only a sodium channel. That we'll have to understand that there are multiple receptors in the nerves. So if you give a clonidine, yes, it can have a like alpha-2 agonist action on the nerve endings, which can block the transmissions. It's very difficult to prove and disprove. Somebody will say that when I give it, it's excellent, and some other person says it doesn't work at all.
Hello, sir. Sir, your internet is unstable.
Yeah, that's when I put off my video.
Yeah, that's why, sir. So the next question: can there be chronic pain in the people who have undergone TKR, sir? Like for 3 months, 4 months, some people are complaining and they are now not walking.
Oh,
is there a possibility?
I have not come across such a patient, sir. Usually, patients are very comfortable on the third day. They're definitely walking around, sir. About chronic pain after TKR, I absolutely hear about it, sir.
Because as the painful areas are resected, the distal end of femur and the proximal end of tibia, the patient will be pain-free. But some patients are continuously complaining. The patient is having pain even after 3 months. That's what I wanted to ask. So I think if, sir, Dr. Shekhar, sir, if sir is not able to reach, I think if there are no more questions, we can wind up the discussion.
Yeah, I feel Neha and this one have had no questions.
So, right. I request Dr. David to propose a vote of thanks. Our treasurer, ISA Pudukkottai.
Yes, sir. Good evening to all. On behalf of ISA Pudukkottai, first of all, I would like to thank our academic chairman, Dr. ALM, sir, for successfully conducting 31st webinar. Thank you very much, sir. And I would like to thank today's chairperson, Dr. Segar, sir, senior consultant and head Ganga Hospital, Coimbatore, for sharing his wonderful experiences. Thank you very much, sir. Also, thanks to today's speakers, Dr. Pankaj Ramkrishna Gupta, sir, and Dr. Neha Kulkarni, ma'am, and Dr. Rahul Vijayanath for excellent academic session. And I would like to thank other faculties, postgraduate, and Kurola A1 Logics for technical support. Thank you. Thank you very much.
Thank you all, sir. Thank you. Thank you very much.
Thank you, sir. Thank you, sir. Thank you, everyone.
Dr. David. Dr. David,
Yes, sir. Thank you.
I think Dr. Shekhar is joining back.
Yes, because sir's inputs were really great. I hope my message was clear, sir, without slides. I know with slides things become more easy.
Sir, I had a question.
Yeah.
Use infusions for TKR.
Yeah, see, my favorite is ropivacaine. Usually the 50 ml vial that we get 0.2%, I double dilute it, put it in the infusion pump, and anything from 5 to 8 ml per hour is what is the usual requirement of almost all patients. If you find that the patient is little fussy, you can think of adding some fentanyl with it, something like 1 microgram per kg of fentanyl. And but most of the time I find that ropin is good enough, and as even Shekhar sir said, we give 8-hourly paracetamol always. And also most of these patients, we put a fentanyl patch or a buprenorphine patch depending on the patient to patient. We put this patch on the previous night of the surgery. So the patient, most of these patches start acting after about 6 hours. 4 to 6 hours is the lag period. So no point in putting a patch on a patient intra. It makes sense to put it on the previous night or early morning of the surgery. So your preemptive analgesia is taken care of. Intra-op, you're giving your spinal epidural, and post-op we continue the epidural and paracetamol. Usually we have found, and of course the patch is also there. Some of these patches are there for even 4 to 5 days. And most patients are very comfortable. The physiotherapy on the first evening itself is quite comfortable. That way. And the ERAS protocol says you, I mean, I feel this ERAS protocols have started off more of, NHS and this hospitals which are abroad, where they want to discharge the patient within 24 hours. I don't think any Indian patient after TKR wants to be discharged after 24 hours. So most of the patients remain at least for 3 to 4 days. So I mean, this ERAS protocol for some surgeries, I feel is definitely not applicable in Indian conditions. Is Shekhar sir back? Or I feel most people have left. And there are some 25-30 people still there. Hello, anyone from the organizing team there? Dr. Meenakshi?
Sir, if no more question,
Yeah.
we can wind up.
We can wind up. Dr. Shekhar was
Ah.
joining back. No, he's not joined back, no?
No, sir, I think it's not.
Great. Thank you,
Yes, sir.
Dr. David. I feel it was a wonderful session. And I
Okay,
would
sir.
really thank on behalf of all the speakers from Nashik that we could interact and not just discuss, we could even learn something from Dr. Shekhar. Dr. Shekhar is a big, very well-known authority in.
Sir, I am there.
There he is. Oh, great, sir. Great to get to hear you, sir, again.
No, I am not so big, sir. There's always learning only.
Right, sir. I told you, Dr. Bala Venkat was 1 year junior to me in BJ Medical College, sir.
Okay, sir.
So we are very close and very close friends, and we have a very great equation.
Yeah, I know that. I have seen you so many times.
Yes, sir.
I am actually senior, much senior. 65 I am.
Yes, sir. I know, sir. He's mentioned about you quite a few times, sir.
Okay, sir. Sure.
And of course, we always come to Ganga.
ALM, sir.
Yeah, I feel we can call it a day. We are waiting for you to come back, sir, because your video got cut off. So we are waiting for you to join, and then we can say goodbye in a better way.
No, he is there or?
Yeah, I feel Meenakshi sir, has left. I feel.
Okay.
There are 26 participants now, and
okay. Thank you to all of you.
Thank you. Thank you, sir.
Thank you for listening.
Yes, sir. Thank you, sir. Thanks a lot for everyone.
Thank
and
you.
I thank the speakers from Nashik.
No more questions, no, sir. No more questions.
No.
So no more questions, sir.
Thank you. Thank you so much.
Thank you, sir.
Convey my regards to Dr. ALM, sir. Okay. Thank you.
Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.
Even logics.